Welcome to VJOncology Podcasts, your source for expert insights in oncology education. Today we're bringing you highlights from the 2026 American Society of Clinical Oncology annual meeting in Chicago. This year's meeting delivered a remarkable breadth of data across tumor types, with several trials poised to reshape clinical practice. In this episode, we hear from 5 experts who are on the ground in Chicago, sharing their perspectives on the trials and results that stood out most. We'll cover advances in prostate cancer, sarcoma, lung cancer, colorectal cancer, and breast cancer, as well as explore what these findings mean for patients in clinical practice. Let's begin. We start in prostate cancer with Mary-Ellen Taplin, who presents final analysis data from the PROTEUS trial, a pivotal study examining perioperative apalutamide plus ADT versus placebo plus ADT in patients with high-risk, localized or locally advanced prostate cancer undergoing radical prostatectomy.
So the PROTEUS trial had 2 primary endpoints and a series of secondary endpoints and a couple very important exploratory endpoints. So the 2 primary endpoints for PROTEUS were the pathologic response of the tumor at the time of prostatectomy, that's an early endpoint, and an endpoint called metastasis-free survival, which is a measure of the patients who develop metastasis or die. And this event, metastasis-free survival, was compared in the 2 groups. The 2 groups were apalutamide and ADT or placebo and ADT. So those were the 2 primary endpoints, major pathologic response and MFS. The secondary endpoints included event-free survival, time to the next therapy, 2 important ones, and then some exploratory endpoints of note are another way to measure the pathology response, which is called residual cancer burden. That takes into account the tumor cellularity as well as the size. And also a way to measure MFS, which instead of having it measured by the blinded reviewers, the central reviewers, the investigators who are treating the patients code the metastasis, and that's called investigator MFS. So those were the most important endpoints of PROTEUS. So we're thrilled with the results. The 2 co-primary endpoints were positive. There was a 10-fold increase in the major pathologic response in the apalutamide cohort compared to the placebo cohort. And additionally, there was a 20% reduction in metastasis-free survival for the apalutamide and androgen deprivation therapy cohort. So 2 primary endpoints are positive, but in addition, some very important secondary endpoints. One called event-free survival, that's any recurrence, was very positive for apalutamide. And strikingly, the time to the next therapy was a 3-year difference almost. It was 33 months for the apalutamide and ADT compared to the placebo and ADT. So we're very thrilled with those endpoints, and they support this type of treatment, apalutamide and androgen deprivation therapy, 6 months before prostatectomy, 6 months after, as a new standard treatment option for men with localized high-risk prostate cancer.
Dr. Taplin's presentation of the PROTEUS final analysis marks a significant moment for the management of high-risk, localized prostate cancer. The demonstration of significant improvements in pathological complete response, metastases-free survival, and multiple secondary endpoints builds a compelling case for adding this next-generation androgen receptor inhibitor to the ADT backbone. Our next guest turns our attention to sarcoma, a disease where meaningful new data has historically been hard to come by. Maggie Zhu from Stanford University highlights several notable findings from ASCO 2026, including results from the SARC-041 trial evaluating abemaciclib in dedifferentiated liposarcoma, as well as key takeaways from the PEAK and MISSION trials.
This has been a really exciting year for ASCO. It's not common that sarcoma makes it into the plenary, so we were really excited to have the results of SARC-41 be presented by Dr. Mark Dixon from Memorial Sloan Kettering. This really establishes a new potential standard of care for dedifferentiated liposarcoma with the demonstration of benefit of abemaciclib over placebo for these patients. We know for these patients that doxorubicin has marginal benefit for many patients, and I think abemaciclib really provides a promising new option for these patients. I'll Otherwise, in the oral abstract sessions, very notable trials I think that were highlighted were the PEAK study for bezuclastinib and sunitinib compared to sunitinib alone, which has a very promising potential to transform care as well. And of course, the Immunome study with varegacestat also provides new armamentarium for our patients.
Dr. Zhao's overview captures a field that is increasingly finding its footing in the era of targeted therapy. The SARC-041 data on abemaciclib in dedifferentiated liposarcoma is particularly striking. CDK4 amplification is a well-established feature of this histology, and the clinical validation of CDK4/6 inhibition in this setting could represent a long-awaited therapeutic advance and potential new standard of care. We move on to lung cancer with Abdul Rafeh Naqash, who offers a comprehensive review of key findings across both small cell and non-small cell lung cancer at ASCO 2026. He discusses results from the Delphi 304 trial of tarlatamab in small cell lung cancer, the Libretto 432 trial of adjuvant selpercatinib in RET fusion-positive early-stage non-small cell lung cancer, and the ALCHEMIST trial of nivolumab after surgery and neoadjuvant chemotherapy.
There's a lot of interesting things happening as far as lung cancer is concerned in this year's ASCO, particularly in the early stage lung cancer setting and the small cell lung cancer track. There is at least 3 abstracts that I feel are of high clinical relevance and importance. One is the CNS, central nervous system activity efficacy of tarlatamab, which is a bispecific T-cell engager, gained full FDA approval last year, November of 2025. And in fact, last year, Delphi 304 was the phase 3 trial that was presented comparing tarlatamab to second-line chemotherapy, which resulted in this full FDA approval. And this year, one of the presentations is on the CNS efficacy of tarlatamab, where they had around 250 patients in each arm and around 50 to 60 patients in the tarlatamab arm versus the chemotherapy arm had baseline brain metastasis with follow-up scans. And in this study, they did show that there was disease-free survival benefit, CNS progression-free survival benefit, as well as intracranial activity of tarlatamab in both patients that had previous treatment, that is SRS or stereotactic radiosurgery, as well as around 25% of patients in the cohorts that were being compared did not have any previous treatment, suggesting that tarlatamab does have intracranial activity and benefit in these patients. And it actually raises the bar for patients with small cell lung cancer who have baseline brain metastasis. So this is very practice informing. We are already using it in the clinical setting, but I think seeing the CNS benefit of tarlatamab through this post hoc analysis of Delphi 304 is going to make it even more important to choose tarlatamab as the optimal choice of treatment for patients with small cell lung cancer. There are also studies that are being presented which are being evaluated in the earlier stage small cell setting where tarlatamab is being used. So more results to watch out for there. The second study that I feel is again very interesting and important is the plenary study that is being presented by Dr. Goldman on the adjuvant selpercatinib in RET fusion positive early stage non-small cell lung cancer. So RET fusions, these are fusions that are present in only 1 to 2% of non-small cell lung cancer. So they're rare, but they're very actionable. Currently, we have 2 FDA approvals, that is selpercatinib as well as pralsetinib in the advanced non-small cell lung cancer setting, both in the first line as well as second line and beyond. But what this trial is doing is in the early stage setting, they're looking at whether selpercatinib offers disease-free survival benefit compared to standard chemotherapy. And as expected, which we have also seen in the earlier stage setting with EGFR inhibitors such as osimertinib or alectinib in stage 1 to 3A non-small cell lung cancer. Similarly, selpercatinib does show disease-free survival benefit in this setting, which again is practice changing. And more importantly, this tells us that NGS sequencing is going to become integral in treating patients appropriately with precision medicines to improve outcomes. The third study, which interestingly is a negative trial, which is the ECOG-ACRIN adjuvant nivolumab clinical trial being presented by Dr. Chaft, It questions the relevance of adjuvant immunotherapy in early stage non-small cell lung cancer. So in the last couple of years, we've seen some major approvals in the neoadjuvant perioperative setting for early stage non-small cell lung cancer, such as Checkmate 816, which was presented last year with an overall survival benefit, as well as the Keynote 671 with an overall survival benefit. And there's adjuvant atezolizumab, which is also approved. But the ECOG-ACTIN study, which was in fact started, the concept developed early on before some of these trials, other trials were reported, but had a co-primary endpoint of disease-free survival in the intention to treat population as well as the PD-L1 more than 50% population. And it was negative for both. But I do think this trial teaches us some important aspects around the utility of adjuvant therapies. And it basically suggests that one size does not fit all. Biology as well as context matters. And there's a lot to learn in terms of contribution of effect in the perioperative setting. So if we give neoadjuvant chemoimmunotherapy followed by surgery and followed by adjuvant immunotherapy, the question that this study begets is that the adjuvant portion actually add much in the setting of early stage non-small cell lung cancer. So a lot to learn there. I think there's interesting studies in early stage being presented as far as ctDNA is also concerned, and their utility as far as MRD and continuing patients on certain therapies. So I think some of these abstracts highlight both how the drug development space is shaping up, as well as questions the notion of placing all patients into one bucket, which cannot be something that we can make further developments with. So we have to basically choose our treatments based on the context, the biology, as well as what matters for the patients.
Dr. Naqash's overview reflects the complexity and momentum of the lung cancer space at this year's meeting. The Delphi 304 data, showing that tarlatamab reduced the risk of CNS progression or death, is a particularly meaningful endpoint in small cell lung cancer, where intracranial disease remains a major clinical challenge. In the non-small cell lung cancer setting, the Libretto 432 disease-free survival benefit with adjuvant selpercatinib in RET fusion-positive patients adds to the growing evidence for molecularly guided adjuvant therapy. The ALCHEMIST trial's failure to meet its primary endpoint is an important reminder that not all immunotherapy strategies translate to the perioperative setting and underscores the need to continue refining patient selection. From lung cancer, we turn to colorectal cancer, where Scott Kopetz presents PFS and OS analyses from BREAKWATER Cohort 3, evaluating first-line encorafenib plus cetuximab combined with FOLFIRI in patients with BRAF V600E-mutant metastatic colorectal cancer.
So the BREAKWATER study is a randomized phase 3 study that was looking at the FOLFOX chemotherapy backbone. After completion of the phase 3 study, there was what we call Cohort 3, which is a cohort of FOLFIRI backbone combined with encorafenib cetuximab versus a FOLFIRI-based control arm. So the study was designed to look as a primary response rate of primary outcome of response rate, but also key secondary of progression-free survival with exploratory analysis of overall survival. These were in previously untreated BRAF V600E mutated metastatic colorectal cancer patients that had not previously been treated with any therapies. Now, the response rate had been reported out previously, demonstrated a very nice improvement in response rate with the combination of encorafenib and cetuximab. But the data here was looking at the progression-free survival. What we saw with the data was that the progression-free survival was in the control arm was 8.3 months, and it improved up to 15.2 months with the experimental arm. So a really substantial increase in that progression-free survival. And this was at least numerically in a very similar range, if not numerically better than what we saw with the FOLFOX, encorafenib, cetuximab, but demonstrated demonstrated the progression-free survival's improvements with this regimen. Now, overall survival is a secondary endpoint, and we have a early readout of about 18-month overall survival. And what we saw was that the median overall survival is not yet reached in the experimental arm, but it was 20 months in the control arm. The hazard ratio so far is right around 0.55 at this early look. So while this is not a powered endpoint, at least shows trends that are very similar to the doubling in median overall survival that we saw with the FOLFOX backbone.
Dr. Kopetz's BREAKWATER data represents a landmark in the treatment of BRAF V600E-mutant metastatic colorectal cancer, a historically poor prognosis population where effective first-line options have been lacking. These results mark the culmination of a decade of research into BRAF-targeted strategies in colorectal cancer and offer a new benchmark for this patient population. Our final interview takes us to breast cancer, where Kevin Kalinsky discusses PFS2 analyses from the ASCENT-04 study, evaluating sacituzumab govitecan plus pembrolizumab versus chemotherapy plus pembrolizumab in patients with treatment-naive, PD-L1 positive, metastatic triple-negative breast cancer.
At ASCO 2026, we are presenting an update in terms of PFS2 and subsequent therapies in patients in the ASCENT-04 trial. The ASCENT-04 trial was the study that had demonstrated that giving sacituzumab govitecan plus pembrolizumab led to an improvement in progression-free survival compared to those who received chemotherapy and pembrolizumab in frontline PD-L1 positive triple-negative breast cancer. And here we're presenting data with PFS2. PFS2 was defined as the time from initiation of randomization to patients who had progression and went on to get a subsequent line or death, whichever occurred first. And we saw that there was an improvement in PFS2 with a stratified hazard ratio of 0.67. And if you look at the SG and Pembro arm, that median PFS was not quite reached. But if you look at those in the control arm, that median PFS was 21 months.
Dr. Kalinsky's presentation of the ASCENT-04 PFS2 data adds an important dimension to the evidence supporting sacituzumab govitecan plus pembrolizumab in metastatic triple-negative breast cancer. The demonstration of improved PFS2 despite crossover is clinically meaningful, suggesting that the combination delivers durable benefit that extends beyond first progression. Together with the broader ASCENT-04 dataset, these results firmly support sacituzumab govitecan plus pembrolizumab as a potential standard of care in treatment-naive PD-L1 positive metastatic triple-negative breast cancer. The data we have heard today reflect a field defined by ambition and momentum. Across prostate cancer, sarcoma, lung cancer, colorectal cancer, and breast cancer, ASCO 2026 has delivered findings that will shape treatment decisions for years to come. What unites these advances is a deepening understanding of tumor biology and an increasingly precise approach to matching the right treatment to the right patient. As these results move from the conference hall into clinical guidelines and practice, their impact will be felt by patients around the world. We thank all of our contributors for sharing their expertise from ASCO 2026, and we thank you for listening to VJOncology podcasts. For more expert interviews and educational content in oncology, visit us at VJOncology.com. Until next time.